Okay, so again, welcome to weekly review, week 4, chapter 7. We're going to start with, which is nursing management of pain during labor and birth. And then we'll go into chapter 8 and just, pick out the highlights of chapter 8. Be sure that you do your reading on these chapters. One, they're really interesting. And number two, is necessary as you think about what's, next week is quiz. And then the week after that, you got an exam two already. So we want to make sure that you're prepared. So let's go over chapter 7. All right. So we all know, and if you haven't had a baby yet, that's okay. You probably know somebody that had a baby, or you've seen it on television. Okay. Those are pretty good things to go by. There is discomfort, or like I'm going to say it, pain during labor and birth, okay? But there's ways to relieve it. And in today's world, thank goodness, the epidural has just been down pat. It is just concrete. And so it's not like years ago where we used to have severe fetal drops, fetal heart rate drops due to an epidural. It can happen, but we have our ways to combat that and combat. Now, another problem with an epidural is mom can get hypotensive. That means her blood pressure goes down. So write that down. So just put right now epidural, and then you put down mom maternal hypotensive. Blood pressure goes down. If mom's blood pressure go down, remember what I said before, baby's going to get affected. So the baby's heart rate will go down. Okay. How are we going to rectify it? Since we're here, we're discussing this. Let's just go ahead and correct it. We can give we can give an IV bolus of 1,000 mLs of LR, lactated ringers. Now, what we do, anesthesia will give the L&D nurse the order. And so we'll bolus her. Now, if she's hypertensive, we're not going to give that much. We'll probably give half. Excuse me. And then we can give her some IV fluids, and that will take care of her having a sudden drop in her blood pressure. Okay, but
Hold on
that
one
was
second.
under epidural. Okay, so we're going to go back now to the beginning of this chapter. But since I was on the epidural, I guess I just wanted to keep going. Okay, Corinzi, did you have a question?
I said, hold on one second. I was finished writing she will receive 1,000 milliliters of bolus lactated ringers.
Yeah, you heard me. Yeah, that we give them a bolus prior to the epidural to make sure that mom's blood pressure doesn't go down. Okay. Because epidurals are great, but they're a form of anesthesia, guys. Okay. She's got to be epidurals, they're numbed from the waist down. They have no feeling. Okay. So yeah, they can have a drop in their blood pressure. Okay. And we don't want that to happen because babies will have a drop. Okay. And since they are numb from the waist down, guess what else we have to put in the patient? She can't empty her bladder. What do you think?
Foley catheter.
Catheter.
Yeah, Foley catheter. It's going to be an indwelling Foley catheter. Okay.
I have a
So,
question.
sure.
Did we do chapter 7?
No, we
No.
didn't. That's why I'm doing
Okay,
it tonight.
I thought I was going a little crazy.
No, you're on track. I figure
Okay.
I go over chapter 7 because when we have an exam, we lose so much time. Okay. So
Yeah.
I thought I go over the highlights with you to make
Mm-hmm.
sure that you got them. Okay. So
Perfect. Thank you.
you're welcome. Okay. So we're going to start in the beginning of the chapter. I kind of started in the middle of the chapter with epidural, but that's the main pain relieving. That it's a pharmacological means, or by all means, because we give medication, but it's what women come into L&D units asking for. They go, "Where's my epidural?" Well, let's see how many centimeters you're dilated, okay? Before we think of epidural. Make sure you're in good, true labor. Okay, so let's start in the beginning of this chapter. Your beginning of the chapter goes over like education. Okay. Now, if you never had a baby, okay, usually there's the fear of the unknown, and I don't know anything about this. All I heard was maybe stories that women told me about having babies, and I'm scared to death. So education is our best tool. So we sent them, hopefully they'll go to prenatal classes, okay? And the prenatal classes are really well because they prepare the woman for childbirth, okay? And your book goes over like three different types. It's called the Dick Reed and the Lamaze, which you probably heard about that. And then you got the other one. Now, what's the other one? Dick Reed. Anybody have? Oh, the Bradley one. Okay. So doesn't okay, put this down. It doesn't matter which childbirth class they go to. Okay. Okay. They all have the similar mechanism. Controlled breathing, women staying in control of their bodies and handling each contraction. Okay. All right. So we're going, doesn't matter, but as long as they attend one. Because when they don't, let me tell you from my experience, when they don't attend a class, I'm having to start at the bottom. I'm having to really re-educate. And when she's in labor, that's not a good time to try to teach someone about breathing when they're in labor, experiencing the pain. Are they really going to listen to me?
No.
No. They're looking at me going, it's just, I want my epidural. And their eyes come real big. And I know you do, but you're only 1 centimeter. So we don't give epidurals at 1 centimeter. Okay. Usually we give epidurals around 3 to 4 centimeters because when we go over stages of labor, we will go over this in more detail. But, that's why I had to teach them, okay, how to breathe. And we'll go over that in just a minute. Okay. And then we have like different classes for everybody under the sun. We have for grandparents, we have for siblings, we have for daddies, mommies, and adolescents. That's the one I love. I love to teach my adolescents so that they understand. Mm-hmm. Do you have a question, Florencia? No. Okay. So I just wanted to make sure you kind of had an understanding that yes, we do want them to go to some kind of classes so that they are in control of their own self. Now,
I do have a question quick before you go on.
oh sure.
You said the childbirthing classes go over controlling breathing, taking
Yeah.
control of their bodies, and what else?
Yes. Well, that's the main two: control breathing and knowing how to handle the contractions so that when the contraction happens, she knows to start doing her slow chest breathing in and out. Then, when she comes to the peak of the contraction, okay, that's when it gets really tough. Then we go to an alternative, which is a lot faster, and it sounds like this. And she can go real fast, real fast. And then when she gets over the top of the contraction that's on his way down, which is called a decreasement of the contraction, then she can go back to her breathing, slow chest breathing.
Okay.
Yeah. And you always want a person, no matter who it is, to stay in control of themselves. Even patients on med surg floor, you all want your patients to feel that they're still in control of them, even though they're really not because they're in the hospital setting, but you give that feeling to them. Okay. And that's quite powerful. All right. So let's talk about now the non-pharmacological means of birth control. Excuse me, of childbirth pain. I'm thinking of birth control for some reason. Let me go to here. Here I got this for you. And I'm going to skip down to where I'm at now. Okay. And I'm going to talk about how childbirth differs from other pain. All right. It does. And what it is part of a natural birth process. If you don't have a child yet and you may be planning in the future, okay, that's fine. If you never have a child, that's okay. But it is different from any other type of pain. Okay. So we all recognize that. And then, you know, a woman, when she goes in for her first baby, okay, she needs a lot of support, because she's going to have these contractions and they're going to kind of be a little scary in the beginning, but as she goes through the childbirth classes, she won't be as much. See, that's what I mean. Those classes are really, they're so valuable to her. And then, of course, thank goodness that childbirth pain is self-limiting and it rapidly declines after birth. Otherwise, none of us would probably be here today if our parents, mothers remember what they went through. Okay, it's a wonderful phenomenon that happens. All right. Um, Again, I talked about pain threshold in the very, very beginning. Everyone has a different level of pain threshold. Okay. I may have one that I can tolerate, these mild, moderate contractions, and some may not be able to tolerate anything. Okay. It's because just that our level of pain, our perception too. And so we have, you want to be relaxed during the contractions in order to open have dilation and effacement of the cervix, because that's what labor is all about. Okay, so write down the power is your contractions. You need contractions to dilate and efface the cervix. Okay, that's what you need. Then, in addition to that, then you have the descent of the baby's head down into mom's pelvis. Okay, and like I said, I think yesterday, the bag of water, if it's still intact, acts like a cushion. Okay, acts like a cushion. But once you do an amniotomy, which is your artificial rupture membranes, you're letting some of that water come down. The head gets more applied to the cervix. The cervix starts to open up more, right? But she feels that a lot more. So there's a lot of times that a woman could be around 4 centimeters, say, and the doctor says, "Well, I think I'm going to break her bag of water." And I always ask the patient, "Are you wanting an epidural?" And she says, "Yes, I want an epidural. Can I have one?" So I asked the doctor. I said, "You know what? Let's plan this out better. Let's give her an epidural. After the epidural, everything is stable. Let's go ahead and break her back water after that." Such a nice thing to do. Okay. Again, is you're planning out your patient's labor, because that's what us nurses do. We are there, labor and delivery nurses, we are there to plan our patient's labor in order that we're successful at the end. We have a positive outcome. So let me go over some non-pharmacological. So you're going to see this again. So non-pharmacological means it's natural. It's nothing to do with medication. It's no medication. Got that? So these are methods that would not harm mom or the fetus, okay? Because there's not medication involved. They don't slow labor down. Narcotic during labor, on the other hand, can slow labor down, okay? Epidurals can slow labor down. And we talked about that the other day with augmentation of labor. If my patient does an epidural and her contractions spaced out, I have to augmentate her with Pitocin. But this way, these natural ways do not interfere with any of that. Okay. Her labor continues at the speed she's doing. So there's no allergies. When you give medication, you always have to worry about allergies. Aren't just one of your questions. Are you allergic to this? And I love when my patient says back to me, "Well, I don't know because I haven't had that drug." I mean, that's what they'll say back to you. And you just take a deep breath and you just be prepared. Okay. All right. We talked about these 3 different types of childbirth preparation. And again, going into non-pharmacological. And I will send you these PowerPoints for you. And the Dick Reed method, it just goes over, the fear, tension, and pain. And then the Bradley method is about abdominal breathing and relaxation. See how they're all kind of together, like I said before. All right. And then you got the Lamaze, which you've heard about that more, the Lamaze type. So this is a really important slide. So this is slide 9, I believe. So These are non-pharmacological pain relief measures. So one is called relaxation. Tense up, you relax. Tense up, relax. Now, what I like the most of is called my Effleurage. Is number 3 here. This is what I like. My patients, well, they sit there on the rocker, okay? So they're rocking. Don't forget, there's no medication involved. She's not being on Pitocin. This is a natural birth, so she rocks, okay? Because pelvic rocking, guys, okay, helps with pain. Okay, so yeah, so they rock back and forth, and then they take their hands, see my hands, and they put it on their bellies, and they rub their bellies, and I'll show you in a circular motion. Okay, circular motion. So right now, take your hands, okay, and touch your belly, and do some rocking, and rub your tummies. Okay, rub around. Oh yeah, does that not feel good? Yeah, that feels good, and you're not even pregnant. So yes, it does. It works. And I tell you, it's so relaxing. And sometimes they even go to doze off, rocking and rubbing their tummy. They doze off for a few seconds. Hey, I'll take it. All right. Then another good one is sacral pressure. So especially during the early part of labor, like in the latent phase of the first stage of labor, they have a lot of back. Okay, so you see my hand? So they take the palm of your hand and they put it right on her sacrum, okay? And the support person or the nurse can just rub her back using counter pressure, okay? It works because when the baby is in an OP position, that means occipital posterior. That means his back of his head is to mom's back. That his head is hitting right against her coccyx. That hurts. And so she's got this terrible back labor. Oh my gosh, she says, my back feels like it's gonna like split open. All right. And they do say stuff like that. So you take your palm and you can put it right there and you can rub. And it's a pretty deep rub, okay? But you do it during the contraction and she just loves you for it. All right. So that's called sacral counter pressure. Now another one is thermal stimulation, which would be heat. So it'd be like going in a nice warm shower, not too hot, but a nice warm shower, and let that. Some of the hospitals even have whirlpools, okay? And years ago, a lot of them had whirlpools, and then they got rid of them because of the infection control situation with cleaning them. And so then they went to showers. So, you have to pick your hospital. And then positioning. Remember, I told you that's one of the P's of the labor and birth process. Remember, I put that in there because labor and delivery nurses do that all the time. We change position. Well, we flip them from side to side. We get them up. We get them on the birthing ball. We have them rocking. We have them walking. Remember, this is normal person, normal low risk pregnancy. Okay, and then we have diversion and distraction. So on labor and delivery rooms, we have beautiful TVs. That's a good distraction. Okay, that could be diversion too. And your husband, or your support person, can be your diversion. Okay, usually they're being funny and they're people having fun, and that's a diversion. That's something to keep her mind off the contractions. Okay, it usually works, I'll tell you, in the latent phase of the first stage of labor. Okay, so the latent phase has 3 different phases to it. And just since I'm here, I might as well tell you, you have your latent phase, is your early phase. So just write that down. So the stages of labor. So you got your, in the first stage, you have your latent phase. Okay, all right. And she'd be dilated from 0 to 3 centimeters. Then you go in from that phase. She's going to dilate more. So now she goes into an active phase, and that's 4 to 7 centimeters. Okay. And then you have the transition phase where it would be like 8 to 10. Okay. And we will discuss that, I believe it's next week, more about the stages of labor. Since you're here, I give you a little tidbit. All right. So, and then of course you're breathing. Okay. Breathing in and out. Now, the best way is to use a combination of these things. Like I said, I have pelvic rocking, doing Effleurage. Okay. And you know, you can have her standing up. You could have her. Oh, I used to take the bedside table for my patient who was in the latent phase and having back labor. Another trick was I take the bedside table, I put a pillow on it, and I tell her to lean over. Okay, when you lean over like that, you're stretching the back. Okay, like I'm trying to do show you. And so when you do that, it takes a lot of that pressure off that low back. Okay, because it is the baby's coming down and hitting her coccyx is gonna hurt. All righty. So, and then here you have a lady doing what we call skin stimulation. Again, you know, she's stimulating the nerve fibers responses that are able to what? To reduce the sensation of painful pain. Okay. These are all very good. They do work. Again, the woman is educated. She goes to her childbirth preparation classes. She's in control of her body. She's working. And if she doesn't have like a strong support person, she can hire a doula. And that's spelled Doula. And doulas are very good. And so make sure you write this down, okay? All right. Okay. So doula is really a good support person. She's well educated herself, and they go through a certification. Okay, and so that they can prepare to help her. She's not a nurse. You don't have to be a nurse to be a doula. You have to go through the classes to be a doula, and then and they're quite intense classes, by the way. I kind of know that. Okay. All right. And then a breathing. Okay. You've heard a lot about breathing. Maybe you've seen on TV where they don't really breathe. They just yell and scream, but we want to have control. Okay. It's better to have control because then the baby's happier too. Because when baby's like inside and he's going through a lot of things himself because mom's in labor. Because when the mom's in labor, that every contraction is pressure on the fetus. Every contraction. And a good contraction to dilate and efface the cervix is equal to 50 millimeters of mercury. That's a lot of pressure being put on that baby. So if mom is carrying on, she's hyperventilating and she's getting numb around her mouth and she's tingling and she's like, oh, nurse. Yeah, the baby's going inside. Hey, what's going on? I'm getting bounced around a lot in here. And so that's what happens too. Okay, so we teach mom how to breathe. So we start out with slow pace breathing. As I said, contractions like a little hill, right? Okay, so when you're going up the hill, we can do slow chest breathing. Just in and out, nice. In and out, in and out, in and out. As we climb up that little hill, okay, we get to the top, that's where the intense pain is. So she might go back to that modified pace or a pattern pace where she goes and she does it fast during the top portion, and then down and when the contraction comes down, it's called a decrement, and she'll go back to her slow chest breathing. You do this, guys, so that she doesn't get hyperventilated. Okay. Again, hyperventilation. Now, what are we going to do if our patient does hyperventilate?
Breathing method.
She can get that little bag that's in her preparation bag. It's a little paper bag and puts it over her nose and her mouth, and she just breathes into it. Or if you don't have a bag, take your hands, cup the hands. Now, everybody do it with me. You should probably see this again. Okay, cup your hands, put it over your nose and your mouth, and you breathe. Tell her to breathe. Yeah, she's breathing. How about that? You cured hyperventilation. Okay, all right. So here is a nice little diagram. Now, this comes right out of your book. Honestly, it does. So I have to give you a book credit for it. It's on page 170. And it just shows you what I was trying to show you. Okay. All right. And how the different types of breathing. The main thing is that you want the patient to breathe. All right. So here I put a slide about hyperventilation. So I just told you all about it. Tingles the hands and the feet, and she's got cramps, and she's scary, and she's already scared because she's in labor. She didn't realize these contractions were going to be like this, Now she's like out of control with her breathing. You don't want to go there. No, I'm going to tell you a true story. I was a young nurse and I was working with this young adolescent, and she was really, really out of control. And I was trying to talk nicely to her and go, now come on now, we can do it together, the cheerleader. And she was looking at me and she was shaking her head and she was like, no, like, the exorcist person. Okay. So I was like, okay, I'm going to try again. And, I said in my sweet little voice, now come on, we can do this together. So one of my doctors heard me and he comes in the room and he says to the patient, if you don't stop screaming, I'm going to take Irene out of the room and you're going to labor by yourself. Well, my face got like this. I can't do that. No. And he said, Irene, what? So then I get real big. And he goes, and she looked at the doctor like, huh? And he said, yeah. He says, this is not what we do here. So listen to the nurse. And so he left the room. And I stood there like, okay. Oh, and he made me, before I even said that, he said, Irene, leave. I was like, okay, I can't leave the patient. Anyway, he told me to leave. So I get by the door and she goes, oh no, I want my nurse. So I looked at him and he looked at her and they agreed that she was going to breathe. Okay. We got through it. She did breathe. We got an epidural and we had a baby. All right. So that's just it's a funny story now, but it certainly wasn't funny at the time. And I was almost like, I can't do that. I can't leave my patient. Okay. So we want to make sure at all times that our patients are safe. Okay. If they're in control of their everything and they're doing well, the non-pathological pain control will be okay. But if she's not, then we have to go to alternative means. Okay. So always remember, keep mom safe. But keep mom safe, we keep baby safe. Okay. Okay. So this is your role when you're dealing with a person that's going for a natural birth. Okay. So we always analyze, okay, what class you went to. And then I have my little nursing care. Okay. I have my nursing care plan on my head, write it down. Everything's good. And then I'm going to see if I can recognize, areas of tension. Sometimes, I'm going to be honest with you, sometimes the support person in the room was not supportive. Okay. Like they say, well, you should be able to handle this. Well, you're not having these contractions. And I felt like saying, yeah, I do agree with that statement, but sometimes it's agitation in the room. So our jobs too is to minimize those and to minimize areas of tension. Okay. So I want to keep her clean and dry and keep her, to relax and to focus. Okay. All right. And, sometimes, everybody wants to be in the room. But I did have a doctor one time, this is going back maybe a few years ago, saying how many people were in the room when the baby was conceived. You think about it. Okay. Who was in the room? Okay. So now we're going to give birth to this baby. How many people do we need to have in this room? Okay. Some doctors are okay with having the entire family in the room as long as they don't create tension. And others are not. So you just kind of feel that out too. Okay. So we have different forms of pharmacological pain management. We have where we use drugs. Okay. So we can use like Stadol or Nubang. So just write those down, Stadol or Nubang. And they work very effectively. Now they will cross the placenta. They will. They travel across the placenta. And so baby will get sleepy on you. Okay. So this is why the timing of these drugs are important. So if she's in labor and she's around 3 centimeters, okay, then that's a good time. I mean, she's still in the latent phase, but she's headed into the active phase where the contractions get a little more stronger. And so, that's a good time then maybe to give a narcotic to take the edge. Okay. All right. Get her through. But remember, every time you give a narcotic, each dose gets less effective than from the very first dose. Okay, each dose. So you give her a narcotic. So maybe you try to get her to at least 4 centimeters. Okay, and then she gets the narcotic, and it takes the edge. Now let me tell you about analgesics and with labor pain. It does not take away the pain of the contraction. It does not. What it does during the resting tone of the contraction, she she's able to rest. So once the contraction pain lets up, after she gets done with the contraction, and there's a resting tone, usually around 20 millimeters of mercury, and she comes down on your graph and you see it, she's able to doze off. Then what happens, it gets her ready then for the next contraction. Okay. She has the contraction, she still feels it, but as soon as it lets up on the decretement side, she is now relaxing. So that's what they do. It does not take away the pain of the contraction. The only thing that takes away the pain of the contraction is the epidural. Now, I have to be careful because don't forget, baby will get sleepy on you. So you have to make sure you position your patient on the left side. Make sure she's comfortable. Make sure you have your IV fluids and all that because it's IV push. Okay. So when you give anesthetics, such as the regional, that's your epidural, you lose the sensation. And we do 2 levels. The first, when you're in labor, you only get one. The first level is at the level of the waistline. Okay. So she doesn't feel the contractions. That's from the waistline down to the feet. Okay. When she has to use, when they have to use the epidural for a cesarean section, okay, it comes up higher. We can redose her, and then the level goes up to her breast. Okay. So then she's able to have a C-section without having to go through another form of anesthetic. It's nice, definitely is nice. Now, if we have a true stat C-section, true stat, where is she's coming in and she's abrupting, then we're going to take her back to the OR very quickly, and then anesthesia will intubate and put her under general. Okay, because we have to get the baby out. We have to save the baby. Okay, so that's a true stat. We call that. Remember, I told you the splash and splash and dash. Okay, we cut real quick. Okay, that's when we use a general. Otherwise, the regionals we like is epidural and a spinal. Now she comes in for a repeat cesarean section. We'll do a spinal, and they do that right in the OR just prior to opening. Okay, so we'll have her in the OR. She has an IV. She has a Foley, and they'll have her sit up. They take the spinal needle. They go into the spinal column, and they'll inject the medication, the numbing. And then soon as that anesthesia takes that needle out, boom, we lay her down, put her on a left lateral tilt, and then we proceed to cut. Okay, that's a spine. All right. So, remember pregnant women, when you're giving any kind of analgesic or anesthetic, you have to remember that they're always at risk for hypoxia. Your GI tract does slow down. Okay. So a lot of times you see women that maybe get to the OR sometimes and they're saying, I got to vomit. Okay. That's because the sluggish GI tract. After they have an epidural, if their blood pressure goes down too quick, they'll vomit. So that's why you always want to make sure that, you kind of do everything you can. I always have an emesis space in a bedside for these patients. And then I gave them IV bolus, and then when I lay them down, you have to be careful. Anesthesia doesn't like too much of a tilt because then she'll get a one-sided block. Okay. But we work with that. We work together because I know I have to keep her off her back. Okay. All righty. So what are your advantages if you have pharmacological means? Well, I can get her to relax and be more comfortable during the resting tone in between contractions. I can have her epidural, and she's numb. from the waist down. Now I have a lot of patients that went to sleep during the time they had an epidural. Now you can, yeah, that's a pretty good epidural. Okay, so they go to sleep, and then sometimes I have to wake them up because I have to do a sterile vag exam because on the monitor I see early decelerations of the fetal heart rate, and I know oh, my baby's coming down. Okay, so I had to say, oh, it could be time for delivery, and they sleep all the way through, and that's kind of neat. Okay, all righty. Again, if epidural slows her down, we're gonna augment with oxytocin. We can handle things. Okay. Let's see here. Your epidural. So I have, let me see if I can bring this up, guys. I have, this is on slide 21. I have a little film on epidural that I'd like to share with you. So let me stop sharing this. Okay. And let me, oh, Kara came in. Hi there. And let me share my epidural with you. Let me, okay. Now this is exactly how an epidural is given. Let me get rid of this. Okay. So you can see she's sitting up. So he's giving her xylocaine there to numb the area where he's going to go in. That's pretty neat, isn't it?
Mhm.
Okay. So that's what I said. My patients, they go to sleep if they get an epidural because they're tired. You know, they've been laboring, so they get tired, so they get that. And the main thing is, and write this down, with epidural, the nurse's role is to hold her shoulders, hold her down. Not we're not pressing down, we're just holding her and watch how the position she's gonna be in. You didn't see it too good on that film, but she's in like a mad kitty cat. So you get you tell a patient put your chin down into your chest. Okay, that's kind of hard when you got a big old belly, granted, but that's why the nurse is standing in front and guiding her. And when you tell her to relax her shoulders, so you all do that with me. Come on. So sit there, relax your shoulders. Come on, I'm doing it, and then push your back out toward your chair, and then get your chin down like a mad kitty cat. See, and that's the position for the epidural. And you work with the anesthesiologist, they'll love you. And then you can, you know, she can get her pain medicine. Okay, all right. So that was the epidural. So I thought you'd enjoy seeing a film. And so again, you have to make sure that they don't move because if they move, they can get a headaches. Okay, and it can nick the spinal column. And so then you have cerebral spinal fluid that's just big. It's just leaking just a little bit. But it's enough to cause a terrible headache to mom. Okay. All right. So we went over all that. So here's your epidural. So you can see here, let me make this bigger for you. Okay, there. You can see here the level like I was talking about. So this here, the level of anesthesia for a vaginal birth would be right here. See, more her waistline. Then if say she has a dysfunctional labor, and we have to go back for a cesarean, okay, birth, anesthesiologist will give her more medication and bring the level up higher. Okay, and that's what we do. And here it shows you what they're doing. So you hear the different pieta matter and all this, and the cord extends. And so here is right in here. See the epidural space? So you can see if she moves, you can nick that column, that cerebral spinal fluid, where the in here. And so sure enough, she would get a terrible headache. So that's why it's important. Now, say she moved and they just nicked the cerebral spinal fluid. Well, sure enough, she gets a headache. So now what she has to have is what we call, let me get small, make this smaller. This is called a blood patch. Write this down. Epidural blood patch. Okay, so the anesthesiologist or the CRNA, they'll perform a blood patch. Now, usually is the person who put the epidural in that's responsible for doing this blood patch, because we're going to have to now, what we do, so watch me. So out of my anticubal space here, they're going to take out 10 mLs of blood. Okay, it's all done under sterile now. Nurses have sterile gloves on, it's a sterile syringe, sterile needle. Okay. And then we take betadine and we're going to clean off that anticubal space. Then they take the needle and we're going to withdraw 10 mLs. Meanwhile, your patient is back in that original epidural position with her lower part of her back out. She don't have a belly anymore because she delivered, but she's going to get that position so they can take that 10 mLs of blood. It's her own blood that's going to now go through that needle, spinal needle, and go right in and seal up. So see, here's your needle, and it's going to seal up. It's going to make a clot right here, and that will now prevent any more leakage of cerebral spinal fluid, giving her this terrible headache. Now, I'll tell you, it works like a charm, because I've had patients come back in and say, oh, I still got this terrible headache. You know, the caffeine doesn't work, Percocet doesn't work. And so we have to then send them to the hospital to have a consult with the anesthesiologist who did her epidural, and they decide they're going to do a blood patch. Okay. As soon as she gets that blood patch, guess what, guys? Headache goes away. It's like a godsend. That headache just goes away. So got to be careful when you're dealing, and if you're called LPN, when you're called back to the L&D, it may be that, you know, they'll say, hey, can you go ahead and Clarenzia, can you go ahead into room 5 and assist with the insertion of the epidural? And Clarenzia says, sure, I remember that from my lecture. And so she knows to hold that patient good in a mad kitty cat position. That's what I call it. And then woman gets a successful epidural. All right. We talked about general already. And because there's, you know, what a general anesthetic, the reason why we use it for emergency cesarean births is because it works instantaneously. There's no waiting time to establish like an effective block. And that's what that means there, to have an effective block so that she doesn't feel it. So yeah, you want to have something on board. Okay. All righty. So, like, what is your role in all this? You know, you got to know it begins on admission. When we admit her into L&D, we're going to get all this kind of stuff, you know, assessed. If she has pain medication on board, you keep the side rails up for only safety's sake. Also, when she has an epidural, we keep up the 2 side rails, which hey, she is. Again, safety's sake. Make sure that the bed, the head of the bed, you know, the height of the bed is down. You don't want it too high, too low. And tell them if they have an epidural, do not try to get up because you don't have any more feeling in your lower extremity. Your legs are not going to support you, and you want to make sure that you educate them on that. And then got to make sure, take a blood pressure, monitoring the blood pressure, and of course, respiratory depression. And if I need to, I will have Narcan bedside if I have any problems with, you know, having any kind of respiratory depression. And then, of course, you're going to chart. Okay. So I have a couple questions if you'd like to see how you do.
Yes. Okay, before your questions, real quick.
Yeah. Who's
What is
asking me? Oh, Clarenzia. Okay, go ahead.
okay, so they when they inject the 10 mLs of mom's blood,
Yeah.
um what is it, the Nick cerebral, like what's the exact name of it?
Oh, the subadenor space, you mean?
What is it called?
The subadenor space.
Subadenoroid space.
Yeah. Let me bring that up again to you. Oh, come here. So let's go up. Okay. Let's see. Go back to blood patch. Okay, let me make it bigger for you. So here's all your different spaces. You know, here's your dura, and here's your vertebral body, and then here's your epidural space, and then here, don't remember, you know, this is your column of your spine, okay? And this is where cerebral spinal fluid kind of lays there, all right? So, and this is all the spine is all the spine processes and everything, but this is where the blood patch is going into. And so if you look on this one, see the subadenoid block in the spinal. This is where the spinal, it goes right into that space. But with an epidural, we don't want to go to that space, okay? We want to go, if you can see it. Oh, why did I use my fingers here? Um, Epidural space is right here, see?
Mhm.
So this is what got, if you do an epidural and she moved, then it gets into the subadenary space, and therefore she has a leakage of cerebral spinal fluid, and therefore she gets a terrible headache. Okay?
Yes.
Okay, you got it. Good question. Love it. All right. So are you ready for a question to see how wonderful you've been paying attention?
Yes.
All right. Okay. Then that was chapter 7, folks. So that was pretty neat doing that chapter. Okay. All right. So if I was to ask you, how does the pain of childbirth differ from other types of pain? What would you tell me?
The woman has like several months to prepare for that pain.
Okay. 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 I got it. All right. Like that. All right. I bet you didn't think of this. Childbirth pain is self-limited. Think about it. Is how you feel, right? So that's called, write that term down. Self hyphen limited is self limited. Okay. Let's see. Position changes relieve pain and facilitate delivery. True or false?
True.
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 Good. Childbirth pain declines following birth.
True.
Yeah, thank goodness. Okay. All right. All right, so that was on one of the slides that I showed you tonight, okay? So that's how childbirth pain differs from any other type of pain. Then the only other pain I can think of that maybe a man can baby, or a woman who's a null parent, who's never had a baby, never been pregnant, um, is having pain associated with a kidney stone. If you ever know anybody have a kidney stone, boy, they suffer. And sometimes they have 4 and 5 stones, and they can really, really suffer. So, like that's how I equate it when I'm teaching men or other women who haven't had babies. Okay, tell me the forms. Okay, I'll ask you the question like this: which are non-pharmacological forms of pain relief? So select all that apply. Okay. Is skin stimulation a non-pharmacological form of pain relief?
Yes.
Yes.
And if you don't know this, write this down. All right. Diversion and distraction are those non-pharmacological forms of pain relief?
Yes.
Yes. Okay. Breathing techniques are they
Yes.
also?
Yes.
Yes. Yes. Good. How about exercise?
Yeah.
No.
No.
No. And yoga doesn't help either. Okay. Could you imagine doing yoga?
No.
My patient would say, "What?" Okay. Which positions and exercises will the nurse teach as beneficial in combating discomfort in the later stage of pregnancy? All right. Would leg lifts be one of them?
No.
No.
No. Good, good, good. How about pelvic rocking?
Yes.
Yes. Yeah. And this is one that you probably haven't heard. It's called Taylor sitting. Okay. And you know how you sit and you have your kind of your legs crossed, you know?
Oh, yeah.
You're sitting up and you have your legs crossed. I can't demonstrate it, but
Like
you know,
Indian style?
that's bad. There you go. Indian style. That's called Taylor sitting. Okay, would sit-ups be helpful?
Absolutely not.
No.
Thank you. Okay. And how about this? I bet you haven't thought of this one.
Imagine doing sit-ups with all that weight.
Yeah.
No. No. How about something called exercise or something called shoulder curling?
Yes.
So what's shoulder curling?
Is that like when you're going like this? Like,
Yes.
yeah.
Like this. Up, bring your shoulders up to ears and come down. Come up and go down. See that?
Yeah.
Am I curling? Yeah, I'm curling.
Mm-hmm.
Okay. All righty. All right. The nurse is providing information concerning non-pharmacological pain control methods. What is a major advantage of non-pharmacological pain control methods?
There's no
I'll ask you, does non-pharmacological sedate the patient?
No.
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 Good, good. Corbin, you say no too, right?
Yes.
Okay. She says she agrees. So no. Okay, good. All right. They do not slow labor.
No.
Good. Exactly. Correct. They do not dull the excitement of the birth experience.
No.
Okay, they don't because you can feel everything, right? This is the excitement. Yep. Yeah.
Mm.
I had a patient that had an epidural. Let me tell you, she slept with the epidural. I had to wake her up to push twice. And then after she had the baby, she went back to sleep. And then she woke up like 30 minutes later and she says, "Is that all there is?" I went, "Good epidural." All right. Does a non-pharmacological do have a potential to cause allergic reaction?
No.
No. Okay. Okay. I think you got the message, the difference between non-pharmacological and pharmacological. Is everybody in agreement?
Yeah.
Yeah.
Yes.
Okay, good. All right, good. So that was chapter 7. Hope you enjoyed chapter 7. And, I was talking a lot about breathing during contraction. And I want to show you what it looks like on the whiteboard. So let me share my screen. Let me go to my whiteboard. And let me show you what a contraction looks like. All right. So, all right. All these different things. Okay. Here, let me just get my pen. Okay, thank you. All these pretty things I got now. Okay, so let me draw a contraction. So here I am. Ooh, I got a contraction. Come down. Got another contraction. And calm down. Let me get rid of this little thing here. Good. Okay, so when I talk about breathing, I talked about the phases of a contraction. So the phase, so write this down, just write down phases of a contraction. So when she's breathing and I'm telling her to do slow chest, that's during the increment. So this here going up, this right here, that's your increment. Increment. Okay. Then as she goes up toward the top, see this top here? That's the strongest part of the contraction. That's called the peak, P-E-A-K, or the acme. You may see that as an older term, but Hesse uses it. Okay, so the acme is spelled A-C-M-E. That's your toughest part of this contraction, is that peak. And so then and she may have to do that pattern breathing I talked about? Remember I said, okay. And then as soon as that contraction lets up and it goes down, it's called a decrepitment. Decrepitment is going down. So remember decrepitment, decrease, kind of remember it that way. And so now I would tell her, go back to her slow chest breathing. In order that now she doesn't hyperventilate, she doesn't get exhausted from doing all this pattern breathing, I want her to try to relax and to blow, blow it away. In and out, breathe in, blow it away. In and blow it away. And that's how you say it. And so she relaxes. And then you have this part here. This is the resting area. This is called resting, okay, relaxation. Okay, so she's not having a contraction. She's basically resting. And then she gets ready for the next contraction because you see it on your graph, and then you see it in her face. She starts to get a little red in the face. And then again, going up is called increment. That's spelled INCREMENT. Increment, MENT. Yeah, increment. And then, so slow chest breathing during the increment. Then when she gets up to the top or the peak or the acme of the contraction, she does her pattern breathing, okay? And then as she comes down, she's during the decrement, she's decreasing, okay? You go back to the slow chest breathing. So that really works, okay? So I wanted to show you that so that you can see the breathing technique using during contraction. Now, does anybody have any questions concerning chapter 7? Okay. So chapter 8, again, is nursing care of women with complications. And we talked quite a bit this week on these complications. So like I said the other day, know the term induction. Okay, induction of labor. Now, don't forget, these are complications that occur during labor. Okay, so these are things that can occur that we have to be prepared for. We're nurses. Okay, so induction is when the woman goes she goes to like late term, which could be 41, 42 weeks gestation. This baby's got to be born. Okay, so we'll do an induction of labor. So, and we're putting her into labor. Okay. We're putting her into labor and using Pitocin. All right, that's what we're doing. Okay, so that's induction of labor. Then we have augmentation of labor, where she might have been in a good labor pattern. We got her an epidural because we just discussed for the past hour. Got an epidural, but now it has what? Wiped out her contraction. So now we've got to augment her labor. So we're going to give her now Pitocin, which is a synthetic version of oxytocin. And we're going to give her Pitocin to get those contractions to start again. Okay? All right. So that's augmentation of labor. Then we talked about the Bishop score the other day. Okay. And the Bishop score is a score that we use, obstetricians, midwives use in order to determine if the induction of labor is going to be successful. So what you're looking at, and it's right in your book, it's a really nice chart, and it's on page 184. And what we're looking at is how many centimeters has she got? Okay. And then for each area that we're looking at, we're going to give her a score of 0, 1, 2, or 3. Pretty good score. Pretty good score. And so she's not dilated at all. If you got a cervix that's thick, and she's 0 centimeters dilated, you better do a 2-day induction, because that already gives you six. You got 0. You got 0 and 0. That's not good. You got to have at least 6 to say you could be somewhat successful. The higher the number, the better. So that's why you can see, if you're looking at dilatation, the thickness, consistency of the cervix, that means effacement. The length. Remember, when we talked about in the first week, we talked about anatomy and physiology of the cervix and how long it could be. Okay, it's for a reason. But as you get closer to your due date, that cervix now goes down. Okay. So it gets thinner. All right. So if I have a long cervix, She gets 0. So you can see the difference in how they do it. And then you have cervical effacement, as I talked about, and then you have position of cervix. The cervix during pregnancy could be facing, remember the cervix, it could be facing posterior. But as she gets closer to term, it's going to move toward the front. So you get a cervix that's more anterior. Okay. And then the last is the station of the baby's head. Remember the pelvis, okay, and you have the ischial spines, because we went over this. Above the ischial spines is minus, -1, -2, -3, -4. Anything below the ischial spines is plus, +1, +2, +3, +4. If her baby's head is high in the pelvis, that means it's above the ischial spine, okay, real high, the baby's actually going to probably be blottable or floating up there. So that's not a good position. So again, you need to probably have a 2-day induction. If you have all the things I just said, you got 0. Okay, and that's not good. All right. So you give a 2-day induction, because remember, our goal as a nurse is to be successful and to have a safe labor and a safe birth. Healthy mom, healthy baby. So again, I want to be successful. So if I'm going to induce her, I want to be successful. If I have to do a 2-day induction, that's fine. I explain that to the patient. And I may have to start with prostaglandins, such as Cervidil, which is gel. And I bring her in, and I put it on saline lock in her arm, just in case. And then I explain to her, I take her vital signs, get the fetal heart rate, and then put some Cervidil on her cervix. Before you do that, and these are always good test questions, by the way, you always get the patient up to the bathroom before putting the Cervidil in. Because once your patient, if she gets up too soon, that Cervidil, what's it going to do? Wham! So
Right.
it's just going to come out. Okay, it's not going to do any good. So you want her go to the bathroom, lay in bed, put your sterile glove on, put the Cervidil, it comes already pre-measured. You put it on your hand, your fingers, put 2 fingers up, and you just wipe it up on the cervix, and she will start contracting. It's a prostaglandin. That's what it's mean to do. And then she starts contracting, and then she'll contract for it usually lasts about 8 hours. And during that time, sometimes you can give her some popsicles or light, liquid fluids, like anything that's clear fluids. And she can have that during that time. All right. So again, that's the Cervidil. All right. It's a prostaglandin that helps to get the cervix ready. And then you bring her back the next day into labor and delivery. Okay. And you check her and you go, oh my goodness, it's great. You went from 0 and now you're 2 centimeters. You went from thick, now you're 80% effaced. Did the Cervidil work? Yes. Okay. And so now you can start your Pitocin induction of labor. Okay. So always, 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 you're taking patients' vital signs, fetal heart rate, make sure the fetal heart rate is good and within norm. What's your normal fetal heart rate?
110 to 160.
Yeah, very good. Okay. All right. So let's move on. All right. We talked about amnio infusion. What that means is that I'm going to infuse fluid back into the uterus. Now, maybe a couple things. What reason why? What do you think? Oh my goodness! You have to be very careful of what you do, because anytime you're going back into the uterus, you could have an infection. Okay, so again, this is all going to be under sterile techniques. Okay, everything is sterile, and I'm going to now put fluid back into the uterus. That's called an amnio infusion. You're using sterile saline, and you use it, you set up your IUPC, intrauterine pressure catheter, and I got that, and I hook up my IV bag with IV tubing and hook it right into IUPC, and then slowly infuse fluid back into the uterus. Now you say, why are you going to do that? One, it could be that she could have variable decelerations of the fetal heart rate that are very low and prolonged because she has a lack of fluid. Okay. All right. She might have lost a lot of fluid when her bag of water broke, and then you labored her now for, say, 10 hours, and she's been leaking fluid this whole time. Well, now the baby gets compromised because he doesn't have enough fluid in there. So for buoyancy and to keep the cord from being compressed. So I'm going to put fluid back in there. Okay. Now, another reason that you might want to do this is because maybe the baby had his first bowel movement, which is called meconium. He may have had his first bowel movement in utero. Okay. And so that's not good. Okay. And it could be green and thick. Okay. Because remember, meconium is tar looking. It's very thick. It's the first bowel movement the baby's going to have if he's born. But sometimes these babies are under stress. And so, and mommy may be going through a rough time. Baby has some distress. He has his first bowel movement inside. You have now the bag of water breaks. You see this greenish, brownish fluid come out, which is not normal. And so you want to dilute that. Again, if I do an amnio infusion, I can dilute that meconium fluid in there. Better for the baby when he's born, because don't forget, we have to suction that out as soon as the head pops out, because put aspirate on that, and that's called meconium aspiration syndrome. Not a good thing. Okay, so that's why we do an amnio infusion. Okay, so the next thing we talked about was aversion. And aversion is just simply with the baby's in a breech presentation. It means when I say presentation, that means what's presenting in the pelvis, the first thing. So when you check and you feel real soft, that means he's in breech. So under ultrasound guidance, I can try to turn this baby. See, I'm trying to turn this baby. Okay. And therefore, then she has a chance of a vaginal delivery. Now, a lot of times we'll induce right after aversion. Okay, because these babies, once we invert these babies, we have a successful version, is called. They go home. You wait to do the induction of labor or her to go into spontaneous labor. Guess what? They love to turn back. Okay, they'll say, "Nope, I don't want that position. I want this position." Okay, and you got to be careful of versions because you can have complications, and sometimes babies are in different presentations because of the length of the cord. Okay, so sometimes they're in a breech presentation because of the cord length. It could have a short cord. So if you have you have to analyze things before you do the version, because if you have that, you can't turn this baby because the baby can die because of that. So you have to be very careful with aversion. Okay, so again, is that a complication? Yeah, a complication that can happen. Now, another complication then can happen to mom is she gets a surgical cut called an episiotomy. Okay, and you have two different types. You have midline and medial lateral. Okay, and on my PowerPoint slide, there is a nice little video on episiotomy. So just take a few seconds to look at it because it really will give you a visual effect. Okay, and so I like the midline better. Okay, now the midline is just straight down. You use a scissor, a sterile scissor. First, you're going to numb her. First, you're going to use a regional called a pudendal block. A pudendal block is given during the second stage of labor, and we're going to numb the pudendal nerves that are right there. So we block that area, and then we can cut, okay? And we only cut as much as we need, all right? So you have 4 different types, 4 different degrees, the first degree, second degree, third degree, and fourth degree. Now you figure the fourth degree is going to go all the way back to the anal sphincter. The first degree is just superficial. Then every degree after the first degree, it's just a little bit more deeper into the tissue, a little more deeper. A third degree, you're getting close to that anal sphincter, okay? Okay, so you gotta be careful, with episiotomies. They got to be kept clean after delivery, and we sew them up nicely, make sure they looks nice, and then they will hurt, especially when her epidural wears off and she's on the mother-baby unit. You're going to apply ice packs to an episiotomy. Write that down. Everybody, I'm telling you right now, write that down. You apply ice packs to the episiotomy, okay? That will take down the edema. It'll help with the ecchymosis, which is called bruising. And so it'll keep it from getting infected. They'll keep it nice and clean too. And we change it every time. Okay. All right. All right. So that's an episiotomy. Again, you got to deliver a baby's head. If the baby's big and mom can only stretch so far, you got to help mom and you got to cut. Now, another complication that can occur is using a forceps or a vacuum extractor. Now, a forceps, remember I told you there's stainless steel blades. Oh yeah, I mean they're hard as anything. They're stainless steel, and so you apply that to the baby's head, okay, straight against the head. And then when mom has the contraction and she pushes, okay, this is during the second stage of labor, she pushes, and so the provider now has his forceps on, and she pushes, he will gently pull, okay? And so that helps mom when she pushes to bring that baby, especially under that symphysis pubis, where it's a intra-rotation, and it gets tough, especially if you have a big baby. Okay. Now, the other form that we can use, it's called an assisted device, is called a vacuum extractor. That's a circular little cap, and we put that on the baby's head, okay? And we use a little pump for pressure and pump up the pressure on it. And then when she pushes again, the physician will pull, okay, on that. And we have the pressure, okay? Now, there's a complication that can occur with that, okay? With the circular, it like leaves a little circular mark on baby's head, by the way, you know, a little round thing. And that can, you know, cause a cephalhematoma, okay, which is a blood clot underneath his head, okay, cephalhematoma. All right, so you can have that from the vacuum extractor. Now, another one is called the caput succedaneum, and that is on the crown of the head. It'll be an abnormal protrusion, and what happens is fluid goes underneath the scalp. Okay, so vacuum extractor, forceps, and the forceps, poor kid can actually come out with facial paralysis, you know, and Erb's palsy from a forceps delivery. So, and they can get all kinds of bruising on their face, you know, because it's tough. Now, I tell you, that's a complication associated with the fetus. Now, with mom, with any of these, she can get a vulva hematoma. And that is very, very painful. So write that down, vulva, BULVAR, hematoma. And that is very painful, okay? She can get that from these kind of deliveries. Because don't forget, that's her skin, and that tissue down there is stretched and is so friable. It's so tender. All right, so she can get that. All right. All right. So those are never good complications, you know. But if you're in a bind, many times I've been in where the head is at, you know, the head's right there. I mean, you know, the caput of the head is right there. I'm going, you're so close, but yet so far, because she has to come around. All right, so that's when they use those forceps and vacuum. All right. The next complication that can occur could be the poor thing, been laboring 23 hours, maybe had a slow progression of dilation. Doctor says time for C-section. I always tell my patients there's two ways of having a baby, okay? But the main thing is to get a healthy baby at the end with a healthy mom. Vaginal delivery and a cesarean. So yes, we do cesareans, and they are major surgery. Okay, it's not like, oh, we're going back to have a cesarean. No, it's when I'm going back with a patient because of a cesarean, I try to say, okay, we're okay, we can do it. It's just, you know, we get in the OR. It's a little different environment, but you're okay. The main thing is you're okay, and then we go on with the C-section. Okay, and again, in our book as nurses, it is a major surgery. So you have to be very careful. She's going to have anesthesia. So you have to be, the anesthesia will be monitoring her blood pressure. You will be in the room. A lot of LPNs help in the room in the C-sections. You count instruments. So you get to know all your instruments. And then you count sponges. And everything has to be accounted for when we close. So we'll have an opening count and a closing and a mid count and then a closing count. And they all have to be the same, okay? Otherwise, as a nurse in the operating room, if you started out with 20 laps with 20 sponges and you end up with you only have 19 that you counted, you have to say stop. Now all these surgeons are going to look at you, okay? And they go, what do you want, nurse? Nurse Sasha, what do you want? And you go, oh, doctor, I only had 19 sponges. He says, well, did you count right? Okay. They're not really nice to you, really. Then you go and you stand, you just get your chin up and you say, I counted, you have 19s, one's missing. Stop closing. You can't close. They have to find them. Okay. And I tell you, if I've had situations, guys, we haven't been pretty, where one of the surgeons put a sponge under the table. And I said, well, we can't find it. You can't find it. I can't find it. Guess what we're going to do? I'm going to get x-ray up here. So before I called x-ray, the surgeon said, oh, I was just joking with you. I have it under the table. They do that. Okay. It's childish, but that's what they do in the OR. It's a whole different environment in ORs. Okay. So, okay. And again, cesarean. So usually we do what we call a transverse incision on the skin and uterus. The one on the uterus is very, very important because that's called a flat and still or transverse. And that one will be low, like real nice and low. And so we have enough room because when you open up, and I've assisted plenty of times on cesareans, when we go in and we cut the uterus, okay? And then I take my hands and I can stretch that uterus. It opens up beautifully. And then I can get the baby's head out, okay? Now, sometimes I'm going to tell you, these babies are stuck in there. And we have to use even forceps to get them out of a cesarean. That's a pretty stuck baby. They get stuck in there. And that's why maybe that baby didn't come down, is because he just couldn't. He tried, but he couldn't. And so, before babies get compromised and get a hypoxia inside, we get them out. Okay. All righty. So that's a cesarean. And then after she comes out, after the baby comes out, the placenta is delivered because we manually take the placenta out. And we make sure we suction all the blood out and we make sure we clean everything out. It's nice. We sew back the layers of the skin, including the fascia, and everything is good. Then she'll get right after the baby comes out and the placenta comes out, she'll get oxytocin. Okay. We want the uterus to be firm. Okay. Just like after a vaginal delivery, after a cesarean delivery, we want that uterus to be firm. Okay. So then after the C-section, she goes to the recovery room and you do her vital signs. And a lot of times LPNs do help out in the recovery room because you can take vital signs, you can assess the patient, respirations, all that, make sure the fundus is firm. She'll have a big abdominal bandage on her. Okay. Make sure that she's not bleeding. Check her lochia. Make sure that she's not passing big clots. And her lochia would be lochia rubra. Lochia rubra. Now, lochia is the term used for the bleeding or discharge that the patient has. So you have rubra, you have serosa, and you have alba. The first 3 days, just write this down now, is called rubra. Okay. The first 3 days is rubra. Okay. So she has cesarean, and whenever you do surgery, there's always risk. Okay, there's a risk to damage the bladder. We can nick the bladder when we go in. So that's why you put a Foley catheter in her before she has the surgeon coming in and cutting on her, because you want to keep that bladder flat. Okay, because there's not much space. Remember I told you at the beginning, week 1, the bladder in relation to the uterus is really close. So if you've got a big uterus, you have a baby in there, and then you didn't have a Foley in, you would have a full bladder. You could nick that so easily. And those instruments, guys, are very, very sharp. Okay. And so in your book, you have really good pictures of cesarean delivery. So you do that. Okay. Last thing I'll talk about is precipitous birth. Okay. So this is labor and birth all in 3 hours. Okay, so these are the kind of ladies that you see the side of the road and they're in the car and they're delivering. Is that, they didn't think they're going to have these, what we call hyperstimuli contractions, one after the other, or tachysystole. They didn't know that. Oh, yes, Nurse Patil.
Yeah, I have a question.
Sure.
So if a woman is in labor, like she's about to give birth, what if the fetus is not in the position? What if it's like head legs down? Would they still proceed?
Well, that would be a breech presentation because you have a foot lane breech. That's what that's called. And so that's an emergency C-section. So I would not have done an induction on her because
Okay.
she was in a breech position. The only time you do an induction of labor is the head is presenting.
Okay.
So when she came in and you checked her and she had the feet coming down, okay, you call for a stat C-section.
Okay.
If she's quite dilated. That's all according to if she's dilated 3 and a little bit of his foot's coming out, that's okay. If she's dilated 6 and his foot's hanging through, that's a stat section.
Okay.
Now let me tell you another story about abnormal presentation. I was a young nurse on the night shift, and just really new. Okay, so I checked this lady, and when I went to check this lady, she was in active labor, and went to check her, and as I got closer to into the cervix, checking to see a dilation, a little hand. Now look at me. A little hand came and grabbed my 2 fingers.
Oh.
Okay. Now that's not normal. That's a complication. That baby was coming down with his arm already through the cervix. So when he grabbed my fingers, I said, woo. Okay. Because don't forget, I'm a new nurse, this is all foreign. And you imagine that, Florencia? I was like, woo. And so I called and I said to my mentor, I said, the baby grabbed on my fingers. She said, no. I said, yes. So she says, that's C-section. Call the doctor. Everybody. 1, 2, 3. IV, Foley catheter, anesthesia, and flying back because this lady was quite dilated. The arm was already coming through. And so that was a good pickup, but it was really quick. Okay. And you imagine she went under general anesthetic because we had to get that baby out. Now the baby did have problems with his arm. He was all bruised. Didn't have any fracture, thank God, but it was all bruised up. Okay, so I'm glad the lady came in when she did because that baby could have died if she tried to deliver that at home.
So a baby will never be born if it's not in a birthing position. So will a baby ever be born like feet first? Like, could you ever deliver a baby?
Oh yeah,
feet first?
I mean, if they come in and they're completely dilated and the feet are right there, we can do a breech. Yeah, that's a breech. Yeah, yeah. But in our world today is so logistics. The lawyers are right there, and so you come in and she's you can do into presenting with the sacrum, and she's not in ready to deliver on the perineum, then we do a C-section. Okay. But doctors are trained, and I did put on a video on delivering a breech on my PowerPoints that I gave you already.
Mm-hmm.
Just take a few seconds and look at that. That's from England. And in England, they really train very well on how to deliver breeches. But we have a lot of lawyers over here, and they're just waiting to get at us. So the United States, unfortunately, we deliver all breeches by cesarean. Okay. Now, and any kind of transverse lie, if you've got a baby that's laying sideways in the uterus, there's no way he's going to be delivered vaginally, Okay. Right. Yeah. Because what's hanging right there is he's laying sideways is his shoulders. You can't deliver. The best position, let me tell you, because you may see this again. The best position is cephalic presentation. That means head first in an OA position. That means that baby is laying inside mom in an occipital anterior position. That means the back of baby's head is facing mom's front, her interior. Okay. I think we go over this next week, but you'll be ahead of the game by knowing this. And so that's the best position. Okay, that's why we know the Bishop score is, it helps, when we're trying to do an induction. That's why we check our patients when they come in and, they want to know they're in labor. We have to determine if they're in true labor versus false labor. True labor, all it means, guys, is the patient's in true labor. Now, write this down, is that she's having rhythmic contractions. Okay, like every, 3-4 minutes, whatever, 60 to 90 seconds in duration, and they palpate, moderately, mild to moderately. And guess this, they when they walk, when we send them out walking, the contractions increase. Okay, so that's true labor. Okay, that's what I know. And I send her out walking, so I make sure the contractions increase. And then she comes back. I check the fetal heart tones. And then it's been about an hour. I'll check them again. And now I should see some type of progression, either effacement of the cervix or dilation. And a lot of times I go, what am I, nurse? What am I? And I say, well, guess what? You made it 4 centimeters. Guess what? We're having a baby today. And they go, yeah. And then the other room I go in, and the contractions had dwindled while she was walking. And she comes back, she says, oh, they're like 7 minutes apart, and some are 8, and I don't know. And I say, and I check her, and she's no progression of dilatation. I say, well, it's time to go home, go take a shower, go rest, and I'll see you later. And they go, no. Okay. And that's because they're disappointed. Okay. So we went over, we were doing precipitous birth. A labor and birth all before 3 hours, okay? Again, is caused by the uterus contracting one after the other. Like, we call that hyperstimulation of the uterus. Another term is called tachysystole, okay? And that means that the contractions are coming one after the other. There's no, like, remember I showed you the resting tone? Okay, the resting space. There is no resting. They're just one hill after the other. Okay. And that uterus is on fire. It just keeps contracting. So a couple things can be harmed. Mom can get harmed, and so can baby. What happens to mom when this baby descends so quickly, she can get lacerations in her cervix, in the vagina, and her perineum. Okay, because she's gonna be delivering this baby very, very quickly.
Yes.
Okay. Yeah. Okay. And so that hurts. Okay. Another thing is that she's prone to a hemorrhage, postpartum hemorrhage, after she delivers so quickly, because the uterus, think about it, the uterus has been firing up. Remember, the uterus is made of 3 different muscle fibers, right? Okay. And so the uterus is firing up one after the other, one after the other, one after the other. Okay. And now she delivers the baby. So the body goes, okay, I'm done. We did our job. Okay. But we got to still, hold on just a minute. We got to keep that uterus contracting after delivery. And remember, she already put out all her oxytocin. All right. So the uterus is boggy and soft after delivery. Therefore, she can hemorrhage because of that. Yes, Nurse Patel.
So do they slow those contractions, or do they let?
Huh?
Do they slow the contractions, or?
Oh, do they feel them?
No, so you said that she'll have contractions one after another without having a break between. So now do they slow them, or do they keep the contractions going?
Oh, usually this happens if they're in the hospital, we can try to slow them down, but usually these patients are on the side of the road, and they're having one after the other. But that's a good question. But we can slow them down. If they come into the hospital, they start having these hyper-stimulating contractions, or you give her too much Pitocin, and they're one after the other. That's one thing. It could be from the Pitocin. We can give them a tocolytic. And tocolytic, such as breathine, are drugs that are off-label that we can relax the uterus with, because they're breathine's bronchodilator. So we can give that sub-Q, and it'll relax the uterus. But we use it off-label. Okay, Yeah, good question. Okay, so we talked about precipitous. Remember, she can go to hemorrhage. Babies can have problems after precipitous delivery is because they come down too quick. So imagine this baby coming down quick, being forced. I mean, these contractions are one after the other. It's a lot of force. And so babies are hitting bone, they can get intracranial hemorrhages coming down. So yeah, they can have problems too at birth. So when you get a baby that's doing good after precipitous birth, you're in good shape. Okay, but you gotta be careful, mom, and baby probably go to NICU for 24 hours. Okay, all righty. I think, oh, the last thing I should hit upon, and then I think we're done, is prolapse cord. Okay, so prolapse cord, you know how the cord is floating beautifully inside, right? Okay, so mom, everything's doing good because the bag of water is intact, right? Okay, so now her bag of water breaks open, but her head of the baby is high up in the pelvis. Remember the station, okay? Visceral spine is right here. Above is minus, right? So baby's like real high. And so when the bag of water breaks and the baby's high, imagine, now look at my hand, the cord can come floating down, okay? It floats down and it goes right in front of the head. And now you've got a prolapse cord. Okay, so that is a obstetrical emergency. So like, for instance, I had this patient come in, triage. I didn't like the way she looked. I was a nurse, I was a manager at the time, and I looked at her and I said, oh, this patient don't look good. So I put her into triage room. I had a beautiful suit on, and I put on the monitor, and the fetal heart rate was very low. It was like in the 90s. Okay. I put a glove on real quick. Didn't take my suit jacket off or anything. I had to get in there because the baby's in compromise. And I did a vag exam. Guess what I found? A pulsating cord right there, right through the cervix. That's why the baby's heart rate was so low, because the baby's starting to lose oxygen. Okay. This baby, she didn't come in when she did, and we didn't jump on her when we did. Okay. That baby could be severely compromised or dead. So I bring the buzzer for help, and I said, I got a prolapse cord in room 2. Before you know, the whole team, because we practice this kind of stuff, it's a drill. The whole team comes in, and I cannot take my fingers out, because what I'm doing with my fingers, guys, is I'm pushing the head up off the cord. And when I did that, he got more blood. Okay. And blood carries oxygen. So we got more of that going now. And so he was like, thank you, nurse. Now I can live. Okay. And so I don't take my fingers out. And guess where we all go? We all go to the OR together. Okay. And I'm in a compromised position because don't forget, I got a suit on. Okay. And so I'm going around, and we go around to the OR. We put her, I'm still in. We put her on the OR table. Okay. And I'm still there. And the surgeon now is coming down on top, and I can feel him coming through. Okay. And I say, don't forget my fingers are here. And then he goes, I know. Okay. And then he says, the count of 3, you get your fingers out of the way, and we got the baby. No problem. Count of 3. 1, 2, 3. I was out. Baby got out. We saved the baby. Okay. That's what us nurses do. That's why from now on, you will look at everybody, no matter who it is, and you'll be assessing them from head to toe. Head to toe. And you'll say, you don't look too good today. Okay. That's what we do. Okay. We save, we prevent things. So this chapter on complications, it's a good chapter. Okay. And then if she's not, say she has a prolapse cord and the mother feels the cord coming through, then if she's at home, let me just add this on to you. Say she calls into 911. 911 is going to tell her to get in the upside down, knee chest, head down, buttocks in the air. Okay. Okay. It's like a Trendelenburg, sort of a Trendelenburg position. And when she goes to the hospital, okay, she will be in that position, head down, buttocks in the air. And we've had them come off the elevator in that position on the OR, on their stretcher. We take her back to our OR on that stretcher. We flip her and cut and get the baby out. So these are things that, can occur. So that's why part of the childbirth preparation classes, we tell them if your backwater breaks at home, just go on the toilet and just take your fingers and feel, because you want to make sure that the cord didn't prolapse. Okay. Again, Trendelenburg position is a great position if they have to. Okay. And I know on Hesse always has a question on prolapse cord, guys. Guarantee it. It's been on every year for 7 years. So you always want to put her into a deep Trendelenburg position for better oxygenation. Okay. What you're doing, think about it tonight on your bed. Okay. Get in, put your head down, put your buttocks up. Okay. And imagine if you had a baby inside, what you're trying to do. You're trying to float that baby up, right? Off the cord. And that's what you're trying to do. Makes sense, correct? Okay. All right. So that is now your chapter. Okay. And the last thing on this chapter was about an amniotic fluid emboli. And that's on page 206. And you probably read that and go, what the heck? That probably never happened. It does happen, unfortunately, and you can lose a patient very quickly. And I have lost 2 that way, where we went to the OR, had a cesarean. This is right now a complication after cesarean. What happened was that the amniotic fluid seeped out and went up into her bloodstream, mommy's bloodstream, her own bloodstream. Okay. And it went right to her heart and she was gone within minutes. We tried to resuscitate and everything. Sometimes you can't save them. And this lady, it was just instantaneously, she was gone. And so it does happen. So when you read in the book, you probably think, oh my gosh, it's terrible, And sometimes you can save them, like I said, but sometimes you lose them. And that's the hardest thing, guys. You imagine I had to take a couple of days off after that. Okay. All right.